Good afternoon and welcome to Grand Rounds today. Quick announcement, there will be no Grand Rounds next Wednesday, but we will reconvene the Wednesday after that. Please remember to fill out the attendance record at the back of the auditorium. Also, please remember to fill out the program evaluations, and as I always do, I'll request that you give us any ideas that you might have in regards to future topics or future speakers. Today I have the pleasure of introducing Dr. Larry Otteman. Dr. Otteman is a member of the Department of Hematology and Oncology here at Mary Greeley and McFarland. He's board certified in internal medicine, hematology, oncology, and hospice and palliative medicine. He's been a frequent contributor at Grand Rounds, and in fact, if we ever have a Grand Rounds Hall of Fame, I'm sure Dr. Otteman will be in it.
There we go.
His topic today is hepcidin, the most important hormone you don't know about, and please join me in welcoming Dr. Otteman.
Thanks to you. Thank you, everyone. Well, I don't pretend that hepcidin is the most important hormone, but just the most important one no one's heard about. So, medicine is art and science, and today it's going to be mostly science, which I think is still pretty interesting, and one of the things that keeps medicine keeps me involved. So today we're going to talk about this hormone, and we'll review a little bit about iron pathways, where hepcidin fits into this as sort of the master controller, and then we'll talk a little bit about different disease states and why this might make a difference. Let's talk a little bit about the players. Most of these you've heard of. Transferrin is obviously the protein that transfers iron, and as you might expect, you need to have a receptor to accept the transferrin. All of us know about ferritin. And then the next ones I think will be new names to most people. Ferroportin is intimately involved with how hepcidin does its work. And then, of course, hepcidin. There's the divalent metal transport 1. And I just spell that out because it is listed in some of the cartoons, and it's good to know what DMT1 stands for. And then probably the newest player in this complex pathway is something called erythroferrone, recently described and discovered. This slide and cartoon I'll spend some time going over, but it's sort of the grand, if you will, grand overall scheme. So we'll start with the intestinal side, particularly the duodenum, which is where iron is absorbed. I'm hoping this is large enough that you can see. Iron is changed from ferric to ferrous, and it then passes through this portal, which is what DMTN1 stands for. So iron out here in the circulation, or excuse me, in the food that we're eating broken down, iron enters the enteric cell. This is free iron there, and then iron has to get out of that cell to be distributed into the circulation, and that's where ferroportin comes in. If you think of it as the portal for iron, that's where the name comes from, and so ferroportin is the important step in that. The iron goes again from ferrous to ferric and gets picked up by the transferrin, and it gets sent into the system. The liver is the source of hepcidin, and I'll say a bit more, quite a bit more later. And so iron is bound finally to the transferrin. It's delivered to the bone marrow. You'll see the TR here is the transferrin receptor loaded with iron. It reaches the transferrin receptor. It goes into the cell, and the DMT1 actually is critical in entering the nucleus and the assembly for hemoglobin. The macrophages, which is the great scavenging system here, as the red blood cells grow senescent or old and aren't as effective, the macrophages are important. And again, here we have ferroportin, this portal which is stored in the macrophage. That's how iron gets out of the macrophage back into the circulation to restore this cycle. So ferroportin is important here, and it's important in the macrophage as well. And then the cycle goes around and around. So red cells to the marrow, red cells die, macrophages recycle the red cells, and then we go round. Now let's talk a little bit about the numbers of iron to give us a little bit better sense of how much iron goes where. If you think of the total body content as somewhere between 3 to 5 grams of elemental iron, and that's split, and some people say 50-50, other people say it's more on hemoglobin, but there are two forms of proteins that require iron. One everyone knows about, which is hemoglobin, and of course the myoglobin, which is in muscle. The liver holds about 1,000 grams of iron as one depot, and then the requirement for iron is actually about 20 to 25 milligrams a day, and it's important to realize that almost all of the iron that we recycle and need on a daily basis comes not from what we eat or absorb, but from the breakdown of senescent red cells. So you can see for yourself, if you need 25, you're going to get 23 from the red cells and maybe 2 milligrams from the gastrointestinal tract. But it's still vitally important for some very simple reasons. And this is another way of going through that same cycle. So the red cells make up about 3,000 milligrams. They become senescent. The macrophages are involved here. Ferroportin, as we talked about, was important to get the iron out of the macrophages into the circulation, over to the bone marrow, that the dietary absorption through the small bowel goes through the ferroportin, and actually the liver releases what little iron it has through ferroportin as well. So the portal for iron is important, and this is where hepcidin comes into play. Hepcidin inhibits ferroportin. So if we need to get iron this way, we need to get iron this way, there's some iron that comes out of the liver, then anything that blocks that portal is going to be important in terms of how iron circulates in the body. And that's why I say that hepcidin is a very important hormone. And again, I trust that most people haven't heard about it. Now, the thing about iron is our body can't excrete iron. It only can regulate iron by either denying it at the GI border or losing it in the form of blood. So either absorbing it from the duodenum or releasing it from macrophages are the only points in this cycle that one can regulate. And I'll talk a little bit about where hepcidin gets its name. This was back in the 60s. One needs to know that pathogens, bacteria in particular, require iron to do what they need to do in terms of surviving, and that bacteria can siphon away a person's iron using something called a siderophore. So hepcidin was a substance that was found coming from the liver that had an antibacterial action, and that's where hepcidin comes from. One of the other things to know about hepcidin is that this is an acute phase reactant, and so very quickly with any type of inflammatory response, particularly if it's being driven by interleukin-6, hepcidin levels go up very quickly. So now we're going to put hepcidin into the cycle, and again, hepcidin leaves the liver, and and then it blocks the portal. It turns off the faucet, if you will, from the duodenum. The hepcidin can actually inhibit what iron is stored in the liver, and then again hepcidin turns off the faucet from the splenic macrophages. So hepcidin turns off the faucet, and that obviously affects the ability to deliver iron to the marrow and to make red cells, as well as delivering iron to other body tissues. As I said, the liver is the major source of hepcidin. It's excreted. Iron in the liver is excreted for ferroportin. Things that make hepcidin go up are iron, can drive hepcidin, but most importantly, inflammation. Things that, I said that incorrectly, things that turn off hepcidin things that turn on hepcidin, I get confused myself. Things that turn on hepcidin are iron, so extra iron, or inflammation. So those are the things that drive the liver to produce hepcidin, and these are the things that block the production of hepcidin where you would want more iron absorbed. So either forming red cells with hypoxia, testosterone or estrogen, which testosterone increases iron, and then a variety of other growth factors can block this blocker, if you will. So again, the hepcidin, the effect on macrophages, and the hepcidin from the duodenum. So these suppress hepcidin, and these tend to stimulate, I said that wrong again. These tend to form hepcidin, which is an inhibitor, and these block hepcidin, which causes the body to continue to release iron. Hepcidin is formed by the liver. It senses the amount of iron through the hepatocytes and the Kupffer cells here. In response to that iron in the transferrin receptor, and we'll show a picture about that, the hepcidin is formed, and again, it blocks the ability of iron to leave the enterocyte. It blocks the ability of iron to leave macrophages. And the way that hepcidin works is it basically binds at ferroportin down here, and it causes it to be taken into the cell, and by lysosomal degradation, the ferroportin is lost. So that's how it inhibits. So it's an irreversible inhibition. Things that regulate then hepcidin, I'll get this right because I wrote it down, are hepcidin is increased if there's an overload of iron. That would seem to be a wise thing. If you've already got too much iron, turn the faucet off. Hepcidin tends to be decreased in iron deficiency, which makes a lot of sense again. You want to absorb iron, but it's increased in acute inflammatory conditions, and that really is a key to a very common problem that we'll talk about here shortly. The other thing is that hepcidin is not easily measured. There is no commercial assay for it yet, but there is a very good correspondence between ferritin, which is also an acute phase reactant, as people may know, and hepcidin levels. And so almost always, if you have high ferritin levels, you're going to have high hepcidin levels as well. This is a paper now about 7 years old on research done about 10 years ago that looked at the role of hepcidin in trying to predict, again, what you would expect. So this is the normal hepcidin level here. CRP is an acute inflammatory source, so hepcidin is highest in acute inflammation. In multiple myeloma, it's elevated for reasons that we don't really know. Chronic kidney disease, both adult and pediatric, especially in adult, hepcidin is increased, which plays an important role in patients with end-stage renal disease and how they metabolize iron. And then, as one would expect, in iron deficiency anemia, hepcidin is very low. And again, that's what you want the body to do. In the diseases of hemochromatosis, if you will, this scale is now expanded from this one here. It's the same hepcidin level. But in untreated hemochromatosis, hepcidin is in the normal range, so it's not completely gone. But in hemochromatosis which has been treated with phlebotomy, hepcidin is essentially gone. And so it's not suppressing the absorption or the release of iron. There's a form of juvenile hemochromatosis involving a protein called hemojuvelin. That's what this is. And again, as a reference, this is iron deficiency. So hemochromatosis obviously is intimately involved with this hepcidin pathway. And we'll talk more about this. A busy slide, but what I wanted to point out is that hepcidin in these four conditions, this is control, iron deficiency anemia, the anemia of chronic disease, and then what we oftentimes see are patients who are both iron deficient and have a chronic inflammatory condition. And that's where the hepcidin is different, as you can see. So with the hemoglobin, there oftentimes is very little to distinguish between iron deficiency anemia, the anemia of chronic disease, or a patient who has all three conditions. And so the hemoglobin itself is oftentimes not very helpful. The size of the amount of hemoglobin contained in the red cell is also not very helpful. There's a lot of overlap here. Now, what we all know is that the serum ferritin can be very helpful in this situation because in iron deficiency, ferritin is nearly absent. In the anemia of chronic disease, ferritin is oftentimes elevated because it's an acute phase reactant, but it can get kind of confusing again down here when there's a combination. And then since ferritin and hepcidin often go together, just the obvious analogy, in iron deficiency anemia, there is no hepcidin detectable. In the anemia of chronic disease or inflammation, hepcidin is elevated, and in patients with a combination, there is at least some detectable hepcidin from that standpoint. So hepcidin can, if you understand the role of hepcidin, I think you can understand the difference between these different disease states. I want to just mention this last player because there is not a lot known yet, but erythropoietin, which is the primary stimulus for red cell production, is involved in this. Erythropoietin doesn't have a direct effect on hepcidin production, so it's not a correlation that's that clean, but erythroferrone is produced in response to erythropoietin levels. So this becomes the messenger that's associated with the drive for red cell production. Now, the interesting thing is that erythroferrone is produced even if there are elevated iron stores. And this is particularly important in children that have chronic anemias such as thalassemias or hemoglobinopathies, because the erythroferrone does have an effect on hepcidin production, and there continues to be an increase or an abnormal amount of iron absorbed even in these children because of their anemia. So you have erythroblasts. The erythroblasts actually produce this substance, erythroferrone, and the erythroferrone inhibits hepcidin, which again, if you inhibit the inhibitor, you're going to increase iron release and absorption. Now, where does hemochromatosis fit into this? And this is a somewhat busy slide, but it's interesting to me because I've never really understood hemochromatosis. I mean, we all understand the clinical syndrome of too much iron and so on, but this, through a lot of research that's been done fairly recently, begins to sort all of this out. So transferrin, carrying iron, attaches to the transferrin receptor. But it turns out that just attaching to the transferrin receptor is not enough. It has to attach to the transferrin receptor 2, and the protein that's important in that process is the hemochromatosis gene. So that's where the hemochromatosis gene gets involved. So it comes over to the cell, and there's this complex of the hemochromatosis gene, the transferrin receptor 2 gene, the hemojuvelin gene, and they're all required to eventually activate hepcidin to turn off the to turn off the absorption of iron. What it does actually is it inhibits this protein which breaks down other messengers, the SMADs, if you will, SMAD4 and RSMAD. And these are actually the ones who go to the nucleus and tell the DNA and the hepatocytes to make hepcidin. So we have inhibitors of inhibitors, which gets pretty complicated. But basically, this complex is how iron sends a message to the liver to produce or to not produce hepcidin. And as one can imagine, that if you have a mutation here, or in the hemochromatosis gene, or in the transferrin receptor 2 gene, and all of them have been described, these are situations where people will be iron overloaded because this inhibition of this signal to the hepcidin allows iron to continue to be absorbed in an iron overloaded state. And there are lots of things that modify how the liver responds to these things. Inflammation has a role on hepcidin, as we said, cell growth and proliferation. Growth signals go through these messengers. Testosterone in particular goes through RAS. And then high iron, low iron, they all basically go through these messengers. But there are a host of signals that work essentially through hepcidin, which is why, again, you don't have to remember all of these things, but you have to remember that it is really the key control mechanism for these different states. So let's talk a little bit about the anemia of inflammation or the anemia of chronic disease. And again, it is now best thought of and defined as an anemia due to inappropriately elevated hepcidin levels. And that's a fairly new insight. Again, all of us who've practiced medicine are aware that there's anemia of chronic disease, but what that was and why it happened and what the intermediaries were have just been worked out really in the last 10 to 15 years. So the anemia of inflammation is the anemia of inappropriately elevated hepcidin levels. You get the anemia. The serum iron, which is released from the macrophages, is not released because of hepcidin blocking the ferritin portal or the ferroportin. The iron builds up, and so there's increased ferritin, and in general, the red blood cells are normal in size. So all of these laboratory findings we knew about, the anemia, the serum iron being low, the ferritin being high, but until recently, we didn't realize that it was all the result of the role of hepcidin. So this is the pathophysiology of inflammation on this sort of teeter-totter. If you have increases amounts of hepcidin, it blocks the ferroportin, you get more iron storage, hepcidin is elevated, IL-6 is elevated. That's what an inflammatory state looks like. In the normal state, there isn't as much hepcidin around. The iron gets through the ferroportin, gets to the red cell, and red cells are produced. So it's really the disease or the anemia of hepcidin excess. One of the things that's been interesting is that once one can define the physiology of this process, then one can start to define the pathophysiology, which is what goes wrong. And not surprisingly, there has been interest in the last few years to see if you can manipulate hepcidin as a therapy. None of this is commercially available, but it will be someday. And I thought I would go through the clinical aspect of what's been purely a science lecture on iron metabolism. Amgen makes a monoclonal antibody directed against hepcidin. Amgen also makes erythropoietin. And then there's a small company called Noxin, which makes a small molecule inhibitor of hepcidin. And we'll look at some of that research. So again, the pathway that we've looked at several times, hepcidin blocking iron through the small bowel, blocking release from the spleen, blocking the release of iron from the liver, so you can't make red blood cells. You take a neutralizing antibody against the hepcidin, and things are better again. The iron can be released from the liver, absorbed from the bowel, released from the spleen, and you can make red cells. So pretty simple, pretty simple. This is an animal model showing the difference that doing both treatments amounts to. So this is an antibody treatment. The antibody is given on these days. And then you can also give erythropoietin. This is erythrocyte stimulating agent in the name in the paper here. And the important part is not so much this, but that if one gives these concurrently, you can see that both, if you give them concurrently, show a substantial rise in the hemoglobin. So this is an animal whose hemoglobin is reduced due to induced inflammation. The hemoglobin is low, and you can restore the hemoglobin not to normal, but certainly at a much improved level with therapy consisting of both the antibody and erythropoietin to stimulate red cell production. And this is true both before treatment and after treatment and the post-treatment. But the important part is that with the combination of the antibody and erythropoietin, you can have a fairly dramatic effect on hemoglobin in animals who otherwise would be running a hemoglobin of about 8. So it does work. That's obviously the first thing you always need to find out. This is instead of animals that have been stimulated with an inflammatory focus, they have the hepcidin knocked out. And so what you can see is that as time goes on, their hemoglobin drops, but if you do the combination of the antibody and erythropoietin, whoops, go back here, and erythropoietin, the hemoglobin is amazingly much better. And so one could envision how that might make a difference clinically with any patient that has inappropriately elevated hepcidin levels. So instead of dropping down to this level, the hemoglobin stays in the normal range with both the combination of erythropoietin and the antibody. So that Amgen combination certainly looks potent. The other one, the other one, which is this small molecule called Lexaptepid, you stimulate it by endoxin administration. Here, the hepcidin goes way up, okay, from that standpoint, and then it gradually comes back down again. In situations where the Lexaptepid is involved, for instance, the serum iron, instead of dropping precipitously, which is what you would expect with the hepcidin, that is the ferritin, or the iron rather, in the macrophages can't be released. The Lexaptepid actually allows iron to continue to be released at much higher levels, which accounts for the improvement in hemoglobin. And likewise, the iron saturation, which just a few hours after giving an animal toxin will drop substantially from the normal range here to 40 to 50, down to 20. Again, the common profile that we see in the anemia of inflammation or chronic disease, the iron saturation is substantially improved. So this small molecule, which inhibits hepcidin, causes the expected results. And this is an oral medication and could potentially be another form of therapy for the anemia of inflammation. This is the particular trial, only a few patients. They were on Lexaptepid for 4 weeks, and the hemoglobin did rise in almost half of the patients. They did not get erythropoietin, and it was just the Lexaptepid itself. But it's entered at least human trials in the earliest stages. So my guess is that before at least some of us are done practicing, there are going to be remedies out there for the anemia of inflammation or chronic disease. This is a very busy one, but I thought I would review where these hepcidin treatments, either the small molecule or the antibody, might come in. So some with iron deficiency, their hepcidin level is already low, ferritin is low, you just give them iron IV or oral. With anemia of inflammation or chronic disease, again, inappropriately high hepcidin levels, this is where an antagonist, either one, would come into play and might be one approach. Because if you remember, hepcidin inhibits or prevents the release of iron from the small bowel, giving patients oral iron for the anemia of inflammation or in a high hepcidin state doesn't make any sense. It doesn't make any sense because the hepcidin is inhibiting the release of iron into the circulation. So if you're going to give iron, you have to give iron intravenously. And that goes along with what's been known for quite some time, which is oral iron for the anemia of inflammation doesn't work. It doesn't work in patients with chronic renal disease, which is why iron is given intravenously in those patients. Again, you might have a mixed anemia, iron deficient and anemia of inflammation, in which case an antagonist along with IV iron would be helpful. IV iron will help with the iron deficiency, and the antagonist would help with hepcidin. This probably also explains why even in patients who are iron deficient, if they have excess hepcidin, don't respond to oral iron. They can't be absorbed through the duodenum. End-stage renal disease, again, that's a high hepcidin state. You have to give intravenous iron. You give erythropoietin, but as Dr. Hallberg would be the first to let you know, giving erythropoietin sometimes is not enough. And I'm sure that in patients who aren't responding to IV iron or erythropoietin in end-stage renal disease, there will be some studies performed looking at ways of inhibiting hepcidin in that patient population to try to restore their hemoglobin closer to normal, as illustrated here. So resistant to erythropoietin, antagonists may have a real role in that particular population. In patients who are ineffective red cell producers and the hepcidin level is low, those patients tend to be iron overloaded already, and all that one can really do to get those patients less iron overloaded is right now to bleed them, but that gets to be difficult. You can try to chelate the iron, but one of the roles may be not an antagonist of hepcidin, but an agonist, something that blocks the release of iron, the way hepcidin does. And then in patients that are iron overloaded because of transfusion, again, chelation is all that one can do. You can't bleed patients that you're transfusing, but an agonist may play an important role in managing those patients. So I think that it's important to know at least about hepcidin. I think it's important to know that it plays a central role, that it helps to explain disease states that we've always known about, the anemia of chronic disease or the anemia of inflammation, the anemia of end-stage renal disease. But as always, once we understand the physiology and then the pathophysiology, we can begin thinking about therapeutic steps. I'll leave this up. That may not be as easily seen, but I'd be happy to answer questions. Mike's got a question.
So, Larry, I didn't know anything about hepcidin either before today, but do you know what evolutionary reason there was for inflammation to increase hepcidin? What on our evolutionary tree made inflammation promote hepcidin?
Yeah. It's a good question, and it actually goes back to what it was originally discovered for. Hepcidin at this point appears to be a vertebrate evolutionary step. But before we were able to produce antibodies, which is a very complex defense mechanism, our innate defenses included the ability to prevent iron from being utilized by microbacteria. Microbacteria require iron for their metabolism as well. And one of the things that I've seen as years have gone on is patients with iron deficiency really do have more rhinosinusitis. It's not just their imagination. So iron's critical in terms of that defense. And so it's part of our body's innate immune system, and it's obviously been adapted for this really important role of handling a terribly toxic element, iron, for essential functions. Yeah, Jim?
Larry, I guess I'm confused. You had end-stage renal disease on your slide
Yeah.
there, and maybe Steve can help us with this one.
Oh.
I was under the impression, and I am easily confused as I'm getting older,
Yeah.
that if you use too much Procrit and get in end-stage renal disease and get the hemoglobin to higher or excessive levels, that creates higher morbidity in end-stage renal patients.
Oh, no, there's no question about that.
Yeah.
I mean, I think there have been a number of large studies that demonstrate that the original studies with erythropoietin, they attempted to get renal patients
Right.
to the normal range, and that was fraught with strokes and MIs. So everyone accepts the fact that you don't want to reach that goal. But if you have a patient with end-stage renal disease whose hemoglobin is running at 7, and you're giving them iron and you're giving them erythropoietin, it would be nice if there was yet something else you could try to do. And so it's that particular group of patients here that are resistant to erythropoietin that I think that the hepcidin antagonist may have the most important role to play in end-stage renal disease. And, we don't see it that often, but, there's still some renal patients who end up getting transfusions because you just can't keep their hemoglobin up. Yeah, Gary?
The increased ferritin in the anemia of chronic disease, it's an acute phase reactant, and the hepcidin is that why both of them are elevated, or is the ferritin reacting to the low iron?
The ferritin acts as an acute phase reactant, just like the hepcidin does. They're both released with IL-6 production.
Okay.
Any other questions? Oh, I'm sorry, Faraz.
That's okay. Where does vitamin C fit in the process of iron absorption in the picture you showed us?
Well, the idea behind vitamin C is that it helps with the conversion of iron from ferrous to ferric, so that it's more easily absorbed. It doesn't really have anything to do with the cellular passage of iron. It has more to do with the breakdown of iron in foods to help convert ferric to ferrous iron so it can be absorbed. Anything else? Oh, I'm sorry?
How can we check the level of hepcidin in the body?
You cannot.
So how can we know? How can we know that it is high or low?
You can't. It's not clinically available as a test. All of the hepcidin research that I've just quoted had to have their own homegrown assay for hepcidin. But there is no laboratory anywhere in the world where you can order a hepcidin level.
If we check the C-reactive protein will help us to know that the inflammation process.
Well, the C-reactive protein is a protein that's released from what's called the type 1 acute inflammatory proteins, which is more an interleukin-1 mechanism. So I don't think the C-reactive protein would be as predictive. Again, ferritin is the other common one that we can measure that responds to interleukin-6 as an acute inflammatory response. So ferritin is one way of getting at likely what the hepcidin level is. But that was the first thing that I looked at too. It's a good question. You know, can I order this test? But you can't at this point. My guess is that if a drug is approved by the Food and Drug Administration and the indication is for inappropriately elevated hepcidin, that there will have to be a biologic test to allow you to measure hepcidin levels. And that seems to be more kind of the drug approval process of the future, at least in our field of hematology and oncology. If you're going to target a pathway, you have to be able to measure the pathway. So that may come, but it's not here yet.
Larry, did they talk about the side effects of the agonists or antagonists in their newspapers?
No, they didn't. It was pretty well tolerated in that one human trial, and the other are all animal experiments, Paul, at this point. So there wasn't really a lot of discussion about side effects, no. Good. Well, thank you for coming to science class. It's quite as sexy.